Thank you again for joining us today. I wanted to take the time to talk about some narcolepsy medications, both old and new. Before we begin, I do have the following financial disclosures. I have been a paid consultant for Jazz Pharmaceuticals in terms of regarding patient experience towards participation in clinical research. I will be talking about some of their products today, so FYI. And then a little bit more about myself. Not only am I the Narcolepsy Network Conference and Research Chairs, but I'm also a person with narcolepsy. I grew up in Miami. I was diagnosed with narcolepsy in 2004. Despite that, I was able to go through medical school and become a pediatric pulmonologist and sleep doctor. I currently practice at All Children's Hospital in St. Petersburg, Florida, and I've been on the Narcolepsy Network since October 2018. So before we begin, I'd like to just start a little on some basic review on what happens with narcolepsy. So as you may know, narcolepsy, at least type 1, is thought to be due to loss of orexin producing neurons in the brain. These neurons project to different areas in the brain that are associated with promoting wakefulness. So as you can see in this first graph on the left, you see the orexin center with projections to different parts of the brain. All these other parts are associated with different neurotransmitters that are associated with wakefulness, and that can be shown in the picture on the right. Now, it may not be important for you to know each and every individual neurotransmitter here, but most of the drugs used to treat narcolepsy will be modifying one of these neurotransmitters, either to increase production or increase effectiveness of the neurotransmitters in the brain. With cataplexy, it's a similar process. We have orexin. Normally, orexin is going to activate different parts of the brain that ultimately suppress a second part of the brain that normally would cause suppression of muscle activity while we are asleep. So it's a little bit of a chain. So basically, your orexin activates something that blocks something that normally would block something else. It's a little convoluted, but that's how most things in neuroscience are. So when on the graph on the right, you can see that when orexin's gone, we see the amygdala, which is our emotional center, actually inactivates the part of the brain that inactivates the part of the brain that causes cataplexy. So it's a little, like I said, convoluted, but it's the same neurotransmitters that are associated with maintaining wakefulness are also involved in preventing cataplexy. So let's go to what's recommended currently. And unfortunately, the recommendations, the guidelines for treatment of narcolepsy haven't been updated, at least not in a while. So the most recent clinical guidelines for treatment of narcolepsy by the American Academy of Sleep Medicine, their last iteration was in 2007. And they currently include Modafinil or Armodafinil, which you may know as Nuvigil and Provigil, sodium oxybate, which you may know as Xyrem, traditional stimulants such as methylphenidate or Ritalin, or amphetamine salts like Vyvanse. Selegiline is another medication not typically used. It possibly due to not as it can be a toxic medication if used in the wrong doses, and it's also the quality of the research that support its use isn't as good as some of the other research supporting the medications typically used. And then finally, we have antidepressants called SNRIs, SSRIs, MAOIs, and others. And their main treatment is towards cataplexy, and they do have some research towards it. However, the backbone on that is more clinical practice that we know that based on other people's experience with use of it, that it works. And that's how this table is set up. So basically, we have the medications here on the left, followed by what they would be treating, followed by the level of recommendation, which means standard means that we have the background research to support it, and we have the clinical experience that also backs it up. Option is that means that we don't have as much research to back it up, but our clinical experience shows that it is an option. And then guideline means we have some research and we have some experience, and it doesn't seem to be harmful. So going on, and I'd like to preface going forward is I'm going to try to tie this together with my own personal experience with using these medications, going over the pros and cons of using these medications, and also trying to explain how these medications work. So traditional stimulants, so amphetamines is one of the first traditional stimulants made. It was first available in 1935. It modifies dopamine, norepinephrine, and serotonin reuptake proteins. So that means that those neurotransmitters, and these are all neurotransmitters that promote wakefulness, they hang out in the space connecting neurons, and basically it ends up causing them to activate the brain cells more for a longer period of time to promote wakefulness. Methylphenidate is also a medication that causes blocking of taking up of these neurotransmitters. Amphetamine has the extra ability that it causes more neurotransmitters to be released, causing more wakefulness. So there are pros and cons with these medications. So the pros is they've been along forever. They've been along probably longer than most of the viewers here have been alive. There are also multiple formulations. So there's you can get medications that are short acting, medications that are long acting, medications that are a combination of short acting and long acting. And you can kind of mix and match. They're also been around forever, so they're usually pretty cheap. Problems with, and then we also we're always worried about addiction with these medications. However, research, at least looking at people with narcolepsy, shows that addiction to these medications are very rare. One thing that is usually listed as a pro for these medications is low tolerance, let me rephrase that. They say tolerance to the effects is rare. That means that it's effective for a long time and you don't get used to it. I put a little asterisk on here because from my personal experience and my experience talking with other people with narcolepsy, that's not so true. After a while, you're still sleepy, but you end up getting some of the side effects. So, side effects can include headaches, anxiety, irritability, mood effects, tremors like shakes, decreased appetite or anorexia, upset stomach, palpitations, feeling like your heart's beating fast, or even high blood pressure. The medication does not normalize sleep, and it doesn't help with cataplexy. And finally, one of the things I always caution my patients with this medication is I'm not worried about them abusing it. I'm worried about others abusing it. Because this can be a hot item, and it could put you as a target for theft, and you don't want to be out of your medications, and you don't want to put yourself in danger. So it's something that if you are prescribed this, you want to make sure you don't advertise that you have it. I like memes, and my experience with these medications is that it gives me a burst of energy that I can get a lot more done in that short period amount of time, but for the rest of the day, I can still be pretty bad in terms of sleepiness. And so that's one of the reasons why I'm not on this medication and haven't been on it for a while. The next medication, Modafinil, Armodafinil, it's considered one of the newer stimulants. It was approved by the FDA. Modafinil was approved by the FDA in 1998, and Armodafinil was approved in 2007. The mechanism of action, its exact mechanism, is not unclear. It definitely has some effect on increasing the dopamine effect, but it's thought to also increase the effect of the other neurotransmitters involved in wakefulness. The pros for this medication is that it's usually very well tolerated. There's definitely less irritability, agitation, and other side effects that are linked to traditional stimulants like Ritalin or amphetamines. There's definitely less rebound hypersomnia. So one issue with some of the traditional stimulants is that As soon as it wears off, you kind of crash. And that effect isn't as bad with modafinil and armodafinil. It's definitely still there, definitely something I've experienced, but it's definitely better than the traditional stimulants. Again, the literature says that there's low evidence for tolerance. I like to disagree because I definitely feel that after a while, the effectiveness may wear off. That's my personal experience, and it may not be true for everyone. Some of the cons include a very rare but serious rash that it can be lethal, and it's called Stevens-Johnson syndrome. And so if you're on this medication and you start developing a rash that seems to get bigger and bigger, you should stop the medication and talk with your doctor. This medication does not help with cataplexy or any REM-related phenomena due to narcolepsy. And then, like I said before, the side effects are more tolerable, but for some people, it's too much. And they're very similar to the traditional stimulants, such as headaches, anxiety, irritability, palpitations. Diversion and risk is also diversion and risk for theft is also a concern, especially in certain circles where it can be used as an academic aid. One issue that I always talk with my female patients who are on this medication is that birth control is less effective when you're on this medication. So I tell all my female patients that, I don't know if you're on birth control or not, but do not expect birth control to actually control unwanted pregnancies. Always ensure that you're practicing safe sex if you do not want to get pregnant, because this medication will make birth control less effective. The next medication is sodium oxybate, and even though it was approved for use in narcolepsy in 2002 and in children in 2018, it originates from the 1960s. Basically, scientists and medical researchers were looking for something that could be used as a sedative or an anesthetic. It activates GABA B receptors, and these receptors, when they're activated, they quiet wake-promoting parts of the brain. Now, it's unclear why this helps with excessive daytime sleepiness and cataplexy, but it does. And it's thought that this quieting of waking parts, of the parts that promote wakefulness, may result in upregulation of these waking neurotransmitters the next day. Now, compare this to baclofen, which works on a similar set of receptors in the brain. Baclofen can improve sleep quality, but typically it's not associated with any daytime improvement of excessive daytime sleepiness or cataplexy. So the number one pro for sodium oxybate or Xyrem, it's an all-in-one drug. It can help with cataplexy, excessive daytime sleepiness, sleep disturbances, and even some REM-related phenomena. There's a strong body of research that shows it works, and it's approved for children, which is important for me as a sleep medicine provider that takes care of mostly teenagers and children with narcolepsy. Cons is that it's a highly controlled substance, and that can make getting it a little bit more cumbersome and difficult. There's always risk for theft, and like I said before, most of these drugs, you always have a risk for theft. Other concerns is that it can make sleep apnea worse, and there are also overdosing concerns that can cause problems as well. Fortunately, this is balanced by the fact that it typically has a short half-life, so it's cleared out of your system pretty quick. Other quality of life factors involved with this medication that are a con is the taste, which is, if you take it, that it's a very salty liquid, and it tastes really bad. Cost is also a factor, as well as food and alcohol timing. And everyone knows that they have to time their dose with their meal. And if they drink alcohol, you can only have one serving of alcohol. And if you have more than one, you can't take it for that night. And then finally, there's that sodium content. So the American Heart Association recommends 1,500 milligrams of sodium a day, maximum 2,500 milligrams of sodium. One night's dose of Xyrem or sodium oxybate is more than that. And so you're already over your sodium content. And so if you have high blood pressure or other cardiovascular disease, this is not good. So just going on with taste. So I did ask Jazz Pharmaceuticals, what can we do about the taste? And they said that they've studied mixing Xyrem instead with water. They mixed it with unsweetened Kool-Aid, lemonade Kool-Aid. This one specifically sweetened with Splenda. So what you do is you make a pitcher of this lemonade Kool-Aid. You sweeten it with Splenda. And instead of mixing the Xyrem with water, you mix it with this Kool-Aid. And they've only studied it with this specific Kool-Aid, but they said that it will not affect the absorption of the Xyrem if you use this. So if you're interested in trying to hide the taste of Xyrem, you can try this. And of course, we've always had the issue of we want to eat, we want to get a midnight snack before bed, but we can't because we have to take Xyrem. And so that's one of another issues that we had to deal with when you have to take sodium oxybate. So the other class of medications used to treat narcolepsy include antidepressants. And so classes include tricyclic antidepressants, which kind of cause a release of lots of different neurotransmitters in between neurons. But it also may affect histamine neurons as well as other neurotransmitters that promote wakefulness. And they mostly work by end result is that they suppress REM sleep and your brain's ability or desire to switch into REM mode or going into REM sleep. SSRIs stands for serotonin reuptake inhibitors, selective serotonin reuptake inhibitors, and they increase the amount of serotonin between neurons. SNRIs and NERIs stand for serotonin norepinephrine reuptake inhibitors or norepinephrine reuptake inhibitors. And so they increase the concentration of serotonin and norepinephrine or just norepinephrine. And studies have shown that the more norepinephrine you release via this way, the better control of cataplexy you have, or like improvement in cataplexy you have, based on this graph right here. So one of the pros of antidepressants is that there's many years of clinical research, and it can help with the mood effects associated with living with narcolepsy as well. Unlike all the other medications, there's a low risk for abuse or theft. Cons include it's important to take every day. It's something that you need to take every day to maintain your levels. If you stop it, you can have potential mood disturbances as well as REM rebound. So basically, the REM sleep will intrude much more often if you suddenly discontinue the medication. Additionally, side effects such as dry mouth, nausea, and sexual dysfunction may make this medication less attractive for use. One of the newer medications is called solriamfetol. It was approved on March 21st, 2019. It's a dopamine and norepinephrine reuptake inhibitor. And recall, dopamine and norepinephrine, they're some of the neurotransmitters involved with improving wakefulness in the brain. In their clinical trials, it showed that it had been effective in maintaining alertness for over a period of 12 weeks and beyond. And so this graph is from their clinical trial. And so what a maintenance of wakefulness test is, it's kind of like the opposite of an MSLT, multiple sleep latency test. It's the opposite. Instead of trying to see how fast you fall asleep, we're trying to measure how long can you stay awake. So we put you in a room, just in a sleep lab, in a chair, no distractions. We hook you up to the sleep equipment, and we see how long you can stay awake. And so most people with narcolepsy have difficulty staying awake during these boring, non-mobile activities. And they showed here with this graph, so basically this bottom line here is the placebo. People at baseline, they could barely stay awake for more than a minute. And when you give the medication, their ability to stay awake is impressive. They go from not being able to stay awake for more than a minute to being able to stay awake for 13 minutes or more. What's nice about this trial was that they also included subjective measures of quality of life, such as ability to work and concentrate. And they also looked not only from the patient's perspective, but also from the doctor's perspective. So they looked at from different points of view to see if this is improving quality of life, and it does. And so this is basically, and they use a measure called the Global Impression of Change scale. And so compared from week one placebo to different doses, you see that the higher the dose, the greater the improvement, and that it persisted throughout the entire study. So pros for Sunosi, it's a very robust wake promoting drug. It's shown to help the ability to work through the day and improves quality of life. It does not affect birth control because it's broken down in the body through a different route. And eating does not alter effectiveness. Some of the cons is that it's a new medication and may not be on a formulary for some insurance providers. So you may have to pay out of pocket, or you may have to pay more for this medication compared to others. It's still a controlled substance, and so there's always going to be a hassle when you have to get a controlled substance as well. Pitolisant is also another new medication that was released in 2019. It was approved by the FDA only for excessive daytime sleepiness. However, it's been used since 2016 in Europe for both cataplexy and excessive daytime sleepiness. Unlike all the other medications I've mentioned before, this one is directly works on the histamine pathway towards promoting wakefulness. It's it's the only one that does this. And this causes suppression of sleep and REM-producing areas of the brain. Its listed side effects can include headache, insomnia, and nausea. And so this graph here is from a 12-month trial looking at the effectiveness of long-term use of the medication. And so with all their patients over the course of a year, you see that there's a great improvement from an average Epworth Sleepiness Scale of 17, which is severely sleepy, to down to about 12, which is mild to moderately sleepy. So one of the pros of this medication is that it can help with both excessive daytime sleepiness and cataplexy, but it's not approved for cataplexy by the FDA. It's only been approved for excessive daytime sleepiness. It is not a controlled substance, so things like refills and getting scripts over the phone is a lot easier. Some of the cons include that it can increase what's called a QTC interval, which is a factor involved in your heart rhythm, and so that can potentially cause a heart arrhythmia if you're predisposed to it. If you have liver issues, or if you have certain genes, you may require an adjustment of your dose, or it may result in too high levels of the drug. Additionally, this drug may also reduce birth control effectiveness. So we've talked about some of the old drugs, some of the new drugs. Let's talk about some of the upcoming drugs that are in the pipeline for treating narcolepsy. So the first one I'd like to talk about is low sodium oxybate. So like I mentioned before, sodium oxybate has a lot of salt in it. And so I put this little picture here because the American Heart Association really wants to control heart disease by ultimately controlling blood pressure. And one of the main ways we do that is controlling our salt intake. And unfortunately, if you take Xyrem or sodium oxybate, you are already over the recommended amount of salt for the day. And that's not good. So this version of Xyrem essentially has 90% less sodium. And so far the trials have shown that it has similar effectiveness to traditional sodium oxybate, and it's currently under priority review by the FDA for use in the United States. Another form of sodium oxybate is the extended release form. It's a once nightly variation of sodium oxybate. This graph shows it's comparing the blood levels of the medication. So they're comparing, the blue line is the twice nightly, the traditional sodium oxybate, and then the the black, gray, and green ones are basically variations of the formulation, and they show that basically the levels are very like stable through the night. And so that basically cuts out that need for a second dose in the middle of the night. Additionally, their studies have shown that there's been a minimal food effect. So that means you can have your dinner and then go to sleep, especially helpful if you're on the go, busy person, like some of my teenagers who have 3 sports and who knows how much, just because, you know, when your narcolepsy is controlled, you can do a lot more stuff. Another medication that's in the pipeline is called reboxetine. It's for cataplexy and excessive daytime sleepiness. It's a highly selective norepinephrine reuptake inhibitor. Remember, norepinephrine is one of those neurotransmitters that promotes wakefulness. It recently completed a phase 2 trial with positive results. They reported that there was improvement in the Epworth Sleepiness Scale. There was decreased frequency of inadvertent naps. There was improvement in concentration ability and improved sleep quality. Finally, I want to talk about an orexin agonist. So basically, instead of targeting all these separate neurotransmitters that promote wakefulness, this one targets the source, the neurotransmitter that people with narcolepsy are missing, orexin or hypercretin. So basically, it's currently in a phase 2 clinical drug trial, and it's hopeful that this is, this will improve wakefulness. So this graph is from another medication similar to what they're testing. It's instead of an oral medication, this one is an IV infusion. So obviously that's not something you can do every day, but they found that with this version of the drug, they are able to improve sleepiness in sleep-deprived normal people. So these sleep-deprived people, they basically kept them awake for a day, and then had them do a maintenance of wakefulness test. And so basically normal people who are sleep deprived, they fell asleep at 9 minutes. And when they were given increasing doses of the medication, they were able to stay awake longer. So the hope is not only would this be able to help people with narcolepsy, but other disorders of excessive daytime sleepiness, such as idiopathic hypersomnia. So I hope you learned something, and I would like to take this opportunity to answer anyone's questions. All right, so I think we already have a few questions already on the list. Let's see. So the first one I got was, can you explain hypocretin deficiency more? So like what I mentioned in the first slide, there's a set of neurons that create this neurotransmitter. It's a protein. It's called hypocretin. It's also called orexin. Once it's released from these neurons to these other neurons, and that triggers those neurons to release their neurotransmitters, which ultimately increase wakefulness. And so it's a small population, a few thousand neurons. They're concentrated in one part of the brain, but they project all over the brain. And specifically towards parts that regulate wakefulness and energy balance. But they also receive connections in terms of your energy balance, in terms of, when was the last time you ate, what time of day it is. So it's really one of the core components of regulating wake and sleep balance. Then the second question was, do you have hypocretin deficiency if you have narcolepsy without cataplexy? So the current thought process is that this is a spectrum of disease. So on one end, you have narcolepsy with cataplexy. On the other end, you have idiopathic hypersomnia. And on one end is probably like a pure hypocretin deficiency. And then as you get to the other end, it's kind of maybe a partial hypocretin deficiency with damage to some of the other structures that maintain wakefulness. And that's still a point of research as to why some people with narcolepsy have cataplexy and some don't. And also, people are questioning, like, if the treatments are the same, the problems are the same, why do we treat them differently? And why do we have to cut them apart differently? And we still have a lot more to learn about that. So the next part is about sodium oxybate or Xyrem. So one question is, can you explain the timing of the second dose of sodium oxybate? So like I mentioned earlier, the sodium oxybate is not in your body for a very long time. Your body clears it out very quickly to the point that you will not have enough of it in your system to do any effect if you only take one dose. It'll be out of your system by 4 hours, or maybe a little bit more than 4 hours. So what the manufacturer recommends is that you have to take a second dose 2 to 4 hours after your first dose. That way you can maintain a good level of that medication in your body so that it can affect your sleep in the positive ways that we want. And so that leads to the second question. And actually, let me take a step back. So that's why things such as having a low sodium oxybate product is important, because you have to take a lot over some period of time with a lot of salt and sodium. And that may not be good for some people, those who have high blood pressure and heart disease. And that's also why people can be excited about the long-acting sodium oxybate product, because now you don't have to wake up in the middle of the night. So that goes into the whether or not what dose is appropriate. And so the manufacturer recommends basically the maximum dose, 9 grams a night. So that's 4.5 twice a day. And yes, you can get acclimated to the dose. In fact, that's the reason why they start you off at a lower dose, because if you start off at the high end, you can be overwhelmed with the side effects right off the bat. And so that's why they have you start off at a lower dose and gradually build yourself up. And in fact, they typically expect most people need to be on the maximum dose to get the most effect. And so it is normal to start on a low dose and gradually build yourself up until you're at the maximum dose. And that should be the typical progression to your final dose. Now, some people, definitely have some people in terms of working them up to the maximum dose, instead of 9 at 8, they're great. And I'm of the thought that if your symptoms are controlled on a dose, I don't need to take you to the maximum dose. And let's just keep it at the dose that works for you. And then finally, is a Xyrem holiday recommended? I don't recommend taking breaks on your medications. I think every day is precious, and every day that you can live functionally is important. And so I don't recommend taking a sodium oxybate holiday. I definitely think that you do recover some of the, it seems to be more effective, but then again, you're missing out on a day or two of your life. And I think there's other factors that come into play why you may be more sleepy in one day versus the other. You may have a longer week. You may not be able to get as much nighttime sleep as compared to the week prior. There's so many other factors that may explain why you feel worse than you did the week before. And I think that going off on your medication is the last thing you want to do. So one question was, what is the timeline for FDA approval of the once nightly Xyrem? Unfortunately, the manufacturer for that one was not able to give me that information when I last communicated with them. However, hopefully with these new sodium oxybate products, I'm hopeful for in the next year or two, we'd be able to see them out into the market. The research on both of them has been pretty much completed, and their safety profiles are very similar to the traditional sodium oxybate. So I'm hopeful that 1 or 2 years we'll be able to see this out in the market. One question was, what narcolepsy drug-related research are you most excited about, and what can we expect in the future in terms of novel treatments? So the last medication that I spoke about, the Orexin agonist, is probably the one I'm most excited about, because it does stimulate receptors that it's basically replacing what we're missing in terms of narcolepsy. And in fact, it works so well, even works on people without narcolepsy who are sleep deprived. And so there are other people with other forms of excessive sleepiness, not due to narcolepsy or idiopathic hypersomnia, that they could benefit from this. And so this is an example of, actually all these medications are examples of how research for a small population with a rare disease can improve the lives of so many more other people. what narcolepsy drug-related research are you, sorry, I already read that one. And so in the future, in terms of novel treatments, I think we're going to be seeing more of these medications that are going to be simpler to take, less cumbersome, easy, less dangerous, and that basically that will have less, we won't have to ask ourselves if the medication's not working anymore. It's going to be more about what's different about my life that I'm feeling more sleepy, because we know I'm more confident that my medication is doing its job. I can review the Kool-Aid slide, but I think we have the recipe on our website. But I'll just review it again. So basically you get those little, those little paper envelopes of Kool-Aid. It has to be lemonade, sugar-free Kool-Aid. You make a picture of that and you sweeten it with Splenda, and you use as much Splenda as you want. And then and instead of mixing the sodium oxybate with water, you mix it with that lemonade, that Kool-Aid lemonade, and you use it, instead of using 60 milliliters of water, you use 60 milliliters of that lemonade. So is there testing recommended before you begin WAKE-X to anticipate liver issues? Actually, no. Typically, your sleep physician may want to ask you if you have a history of liver issues, or if you've had any kind of I would say not quite overdose, but basically an adverse effect with other medications that might suggest that your liver doesn't break down medications as quickly as other people. If you definitely do have a history of liver injury, your doctor may want to order a liver function test, which is a blood lab work, before they prescribe that, just to make sure your liver function is going well. I did mention the heart rhythm issue, the heart rhythm concerns, and unless you have a previous history of heart rhythm issues, you don't need to be tested or screened for heart rhythm stuff before you start WAKE-X. I would only do that if we already knew that you had a history of that. Otherwise, the risk of having any arrhythmias without any previous history is low. Does eating food affect the other medications? So the most notorious one is going to be Xyrem. So if you take food with Xyrem, then your end levels of Xyrem are going to be much lower, and you need them to be a certain level in your body for it to be effective and to see those positive changes that we want in our sleep and the next day sleepiness levels. And this is why these newer medications are really also exciting as well, because both the low sodium oxybate and the once a night sodium oxybate, the food does not appear to affect the absorption as much. The antidepressants doesn't seem to be affected as much. And so that's one of the reasons why reboxetine is a nice, might be an interesting thing in the future. And then, yeah, eating and food, it's a hard balance, but then again, I think that we all need to be mindful about what we eat and when we eat. And so this is kind of forcing us to be healthy. And then finally, next question we have is, can a person with narcolepsy function well without medication? I've certainly met people that report that they function well without medication, that they may function well with a few cups of coffee or a few Red Bulls. I mean, caffeine is a medication, we'll be honest here, but other than something that you can get over the counter, I've met people that say they do. However, I think it's an individual question as to how you want to feel and what you can accomplish without medications. I know myself, I need medications to function well. And it's kind of like a individual basis, and you just got to compare yourself, how you were before you started medication and how you are with after, and that can be difficult if you've been on medications for a long time. But I know myself that my ability to get stuff accomplished and achieve my goals is significantly diminished without medications. Are any medications safe to use during pregnancy and nursing? That's a really tough one, and that's always a big question. So a lot of these medications have either like a class B or a class C pregnancy lactation warning. So basically which means that either there's not enough research to show that it's safe in humans, like there's no evidence that it's bad, but there's no evidence that nothing bad will happen either. So it's kind of like a mystery as to whether or not something bad will happen. Others like class C, that there's animal research that shows that it might be bad for pregnancy, but there's no human research that shows that it's bad for pregnancy. And we've seen women who got pregnant with these medications and nothing bad happened. But it's really hard because like some of this info is missing. And I think with these newer medications, the people who are creating these medications, that they're really more taking that into consideration and following this up. So they release the product, they're gonna look after the medication's been released and follow people who get pregnant so they can better identify what the risks are. And so being pregnant with narcolepsy is really difficult because you got to make a choice. Like, do I want to risk something happening to my pregnancy versus still being functional? And from what I understand, talking with my family members, my patients, pregnancy is already tough. It's already tough to be pregnant even without narcolepsy. And so having to go off your medications is, a double whammy. And so it's something that you have to, it's a conversation you have to have with your sleep doctor and your obstetrician as well. And I think that is the last question. So just a reminder, we're gonna be taking a break in a few minutes. It's gonna be about a 10-minute break. I want you guys to remember our next session is gonna be our NIA class, which is an exercise session. So I want you guys to put on something comfortable, shorts, t-shirts, some sneakers, or maybe on just a soft surface, no shoes, and have plenty of space to do some movement. Make sure you have a bottle of water or some liquid to drink while you're doing this as well. Don't want you to get dehydrated. After the next two sessions, we'll still have Q&A after each session. Make sure to submit it through the Q&A function. Try to keep things to the end because we may end up talking about something that answers your question, and it helps us keep track of the questions for us to answer at the end much better. And again, thank you again so much for participating in our Narcolepsy Network Virtual Patient Education Day. I'm thrilled to see so many people watching, hearing, learning, and asking really good questions. And so we'll see you again in about 10 minutes. And otherwise, have a nice day, and I'll see you later.